Hello and welcome. You found the Social Work Podcast. My name's Jonathan Singer, and I'll be your host as we explore all things social work. Today's podcast is the second in a two-part series with Mary Rauktis talking about measurement. In today's podcast, we talk about the difference between measurement in the field and measurement in research settings. We talk about some of the challenges social workers have using measurement because of training, and we talk about some ideas that might be useful for schools of social work who are interested in incorporating measurement into classes other than research. We also talked about some resources that social workers can follow up on. We ended with some ideas on how social workers can really develop their own measures and think about measurement as a tool for improving their own practice in the field. In part one of this series on measurement, Mary and I talked about how she became interested in measurement, the purpose, key concepts of measurement, including reliability, validity, and error, and what to look for in a research article when thinking about measurement. Without further ado, on to the interview with Mary and measurement. Mary, in the first part of our conversation, we were talking about what was the purpose of measurement, what were some of the key concepts in understanding measurement, and we talked a little bit about measurement in research settings versus, the field. But I was wondering, are there differences between measurement for research and measurement that clinicians would use in the field?
There are differences, but there are also similarities. Regardless of the purpose, if it's for clinical practice or if it's for research, you want the measures that you use to have good psychometric properties. And internal consistency, for example, is important. The reliability piece I talked about earlier. If they've been used in other studies, what have people found? For clinical reasons, I would always look for something that is brief, with clear language, and that's comprehensive but not redundant. For example, when we began to reconceptualize restriction and the restrictiveness of living environment scale, the rules, one of the things that people said to us very, very clearly when we talked to clinicians and practitioners about it was, absolutely, this needs to be revised. We need something new, but don't change it, which sounds like it is a contradictory message. But what they were saying to us is, this is short. We can do it very quickly. It's in language we understand. It's not redundant, so don't change that piece of it. And it makes sense to us. It has face validity for us. And so for practice measures, I would always look for something that wasn't overly redundant, was short, precise. And oftentimes that's why in clinical practice you see measures oftentimes like the CGAS for children, the clinical general assessment of functioning scale, which is actually you're I believe going from 0 to 100 and coming up with a number, and it covers many things. Actually, it's functioning. It's rather general. You oftentimes will see these sort of general measures being used in clinical practice because it gives people sort of a place to put a stake, so to speak. This is what I think I'm seeing overall in this child or this adult's functioning. In research, oftentimes you have measures that might be more redundant. Because you're interested in generating new knowledge and less about using information to make decisions, you might see longer measures, multi-item, where you might have 106 items about something. Doing 106 items in the field would be very time-consuming, and most clinicians won't do it. But in a research setting where you have perhaps more time and it's not being used to make decisions about clinical care or effectiveness of care, then people might be more willing to do this. And it's really about generating knowledge as the purpose. When I think about using measurement for clinical practice, it's really about three things. One is decision support, using the information to make appropriate decisions at key points. Okay, so I'm using this REMY, for example, to determine whether or not this child can move up a level because they've been here for 2 months. I'm using it for outcomes monitoring. When they leave, I want to see whether or not they're leaving to an environment that is, again, less restrictive perhaps than the one that they came from. And then the third purpose for me would be I'd like to use it for quality monitoring. How sensitive is this to programmatic change? Does it tell me if my program overall is doing well or if it's not? And so the utility piece of it, for me, measurement in clinical practice is really about decision support, outcomes monitoring, and quality monitoring. And if you're interested in this area, there's actually a very good book that addresses this in more detail by John Lyons and Dana Werner. It's a chapter in an edited book by Mark Murish called Measurement as Communication and Outcomes Management. And so in this case, they're talking about the utility of measurement for clinical practice.
Okay, and we can put a link to that book on the Social Work Podcast website at socialworkpodcast.com. So it sounds like those are a couple of important differences when I have worked with measures. This issue of face validity has come up. I'll sit there and I'll say, you know what? These questions have nothing to do with the kids that I'm working with. Or, this is great, but what do I do with it? Then it sounds like that's really important, because if you have a measure that was created for the creation of knowledge and somebody has told you to use it in your agency as a clinical measure, there could be a big disconnect.
Yes. The best,
Not that ever happens, of course.
Oh, never. No, Jonathan. Actually, I have a wonderful quote from a parent about one measure that we were using, and she said, "This is great. This just doesn't tell me what's wrong, but it tells me what needs to happen." And that, I believe, sort of encapsulates this whole idea about measures, the utility of it. It's just oftentimes measures used for research purposes aren't necessarily telling you what to do with it. They are operationalizing depression or opposition, etc. But measures that are designed with the end in use, decision support, effectiveness, of treatment, and quality monitoring, have that end in mind, and they may look different and are focused on that idea. It tells me what to do. It gives me some guidance about what to do. And so I believe that when parents, families, clinicians have the opportunity to use those kinds of measures, they're much more likely to use them because it gives them sort of the map. Now, on the other hand, I will tell you that that's not necessarily something that happens. It doesn't happen automatically. People need a little bit of training to do that. People need some help in. Unfortunately, what happens is people perhaps will use a measure with someone and then they'll put it in the record and they'll go on to write whatever they were going to plan to write anyway for their treatment plan. And so people actually need to be coached about how to take that. Again, if it's a tool that was really designed for clinical decision making and for outcomes monitoring, they need some help in taking that and translating it into goals into a plan.
I'm thinking back when I worked in Austin, and we had to do the child behavior checklist, box CBCL. And it's 113 items, and that was always fun. And we had our administrative assistants who could score it. Mm-hmm. And there was usually a 1-week turnaround time. And I don't think anybody ever used the CBCL as part of treatment planning. It was a regulation. We had to get it at intake and then again at 90 days. Although I'm not sure that the CBCL was normed for 90 days. I think it was actually 6 months, which is another issue. Yes, it is. Using a measure differently than what it has been tested for. The second issue that it brings up is there's this agency issue. How fast can measures be turned around? How fast can you get the information? How to use it? But the other thing is that my experience is that schools of social work don't train social workers on administering assessments or the interpretation of assessments. That's really seen as a psychology thing. And so there's a disconnect again in what you're saying about if you're out in the field, and it's not just like, one-on-one, your traditional therapy, but you're working in a residential treatment facility, you're working in inpatient, you're doing case management. It sounds like there are measures that can be used, but these are not things that schools of social work actually train folks to do.
I agree with you. I think that education and psychology are actually, schools of education and schools of psychology are much better at training students in that area. For example, I have a master's degree in education, and we had 2 classes on testing. And just not traditional testing in terms of IQ testing, but also a full range of testing, from career testing to testing for depression, anxiety, etc. So that's a part of the curriculum. I would agree with you, Jonathan. My experience is that there's much less emphasis put on this in social work historically. And what happens is people come out to practice in the field and they learn it on the job. But they don't always learn it very well on the job because there often is not the time to learn. And so what typically happens, having worked in a provider setting for many years as a director of research, what happens is that this gets rolled into training perhaps on treatment plans, which are often very much dictated by funders. And so it gets much less emphasis. People learn it in the field, but it really doesn't receive the time that it deserves. And I've done, for example, recently some interviews with child welfare workers about how they make decisions. And I find it really interesting that very few of them mentioned how they use a risk assessment matrix in making decisions. And
is this risk assessment matrix something that they're required to do?
Yes.
Or they're trained in using?
Oh, they're very much. They are required to do, and has extensive training. And so it makes me wonder if decision-making processes, and this is a fascinating area and beyond the scope of this podcast, but how we can help people change the scheme of how they make decisions to include measurement as a source of information. One piece, but not the only piece. Obviously, a lot of things come into play. I'm finding out their past, what they know from the past, how they were raised, what they've learned in school, but also this piece of information that they've collected in a systematic way so that becomes more natural in the decision-making process, because I don't think it happens naturally all the time. And then if people don't learn it in their master's programs and they learn it sort of haphazardly in the field, I just don't think it gets used very, very well. As you mentioned, what happens is you do it to meet regulations and then it goes in the record and that's it.
As we're having this conversation, I'm wondering if it would be useful for students to receive information on measurements, not just in a research class, but in their practice class or their community organizing, whatever it is that they do. Mm-hmm. To have something built in to where you say, okay, so we're talking about depression, we're talking about family therapy, or we're talking about working with people in the community. How would you measure this idea? How would you answer this question? How would you help people to answer this for themselves?
The way that we teach measurement is that we teach it we pull it out of context, and that isn't how people learn. My dream
tell me your dream.
My dream would be that research, in particular measurement, would be integrated into all classes in social work, so that people in the clinical tracks are learning about measurement as part of evidence-based practices, that it becomes part of their language, that in community organizing, that the measurement piece is part of the classes, the curriculum, and just not a separate research class. That in administration, that people are talking about and using assessments of burnout or secondary trauma, etc., that it becomes not pulled out of context but integrated into those classes. That would be my dream.
I think that's a very reasonable dream to have. I know that in the practice theories course that I taught at the University of Pittsburgh, we incorporated some of Scott Miller's scales, outcome rating scale, and the session rating scale. And students were really excited about that. They really found it, I think, reassuring to know that they can administer a 4-item scale at the beginning of a session, at the end of a session, every couple sessions, gather data, be able to explain it to their clients, have their clients provide feedback, and sort of engage in that sort of scientist practitioner model. And it fit. It wasn't something that was like, oh no, okay, wait, didn't I take my research class already? It really fit, and I think it enhanced the practice theory course.
And I think it could be a natural enhancement of classes about supervision, administration, just not in your clinical classes, in your community organizing classes of social theory. Sometimes social workers come into the Foundations of Research class that I teach, and they say, well, I'm really not a researcher. This has me very anxious. And I hope at the end of the class that people leave with a real sense of excitement about the fact that they do research all the time, that they can. It's not separate, something that's done to them or they bring someone else in to do, but they do it in the process of working with people, as you just described, through Scott Miller's work, or if they're supervisors, as social workers often are, and they're working with new therapists or new clinicians, that they can do the same kind of process with their supervisees. How, in terms of assessing how the supervision process is going, what they're learning, what they're not, where they need help, that this doesn't perhaps need to stand up to the same level of scientific scrutiny, for example, if they were doing it for another purpose. But for the purpose they're doing, it works, it makes sense. And most importantly, they come out with the ability to do that from a school social work.
I think one of the challenges then to using measurement in the field as we're having this conversation is because students don't leave having studied 10 or 15 different scales, or they don't have in their back pocket a couple of things they can pull out that they're really comfortable with. The question is, out of the millions of scales that are out there, how do you know where to get them? How do you know which ones to use? How do you even know what's available? And you talked briefly about some resources, but do you have other ideas for resources and places that social workers can go to not just learn more about measurement, but to find some measures that they can use in their own practice or in the community?
Yes. Well, there's always a great resource book called Measures for Clinical Practice by Corcoran and Fisher. And I believe they're on their 3rd edition, might even be 4th at this point. And that's
through Oxford University Press.
Yes.
It used to be through Free Press, but they changed publishers. Right.
So, I'd like to think that every nonprofit might have a copy of this, but I know that isn't always true. But that's a great resource to go to. I mentioned the book earlier, The Use of Psychological Testing for Treatment Planning and Outcomes, edited by Mark Marouche. We'll put the link to that. That's relatively recent, 2004. Also, I think a great resource for people is actually the Internet. Now, again, lots of stuff out there that you want to stay away from. So it's really a mixed bag. But if you use something like, say, Google Scholar, and you begin to search that way, so say you're interested in trying to find a good measure of, social support. Well, you can type that in, and then you'll start to get some citations. Now, many people in practice settings don't have access to electronic databases the way we do at the if you're sitting at a university. So I know that myself, having worked in a practice setting. So what do? You can't necessarily get the PDF of that article that you're interested in. Well, oftentimes in the abstract, they'll have the emails of the authors. I encourage people to email the authors and say, I'm very interested in what you've written about in this article. I can't easily access a copy of it, but I wonder if you could send it to me or tell me more about your measure of social support. I find that people are remarkably generous with their time in doing this. I get many requests for things like the roles or the REMY, and I'm really glad to respond to people, to tell them where to go, to send them articles, copies. And so there's a whole community. The great thing about the Internet, I believe, for measurement purposes, it has opened the community up a little bit so that you don't need to necessarily go to a reference book, although those are great resources, but that you can, if you're sitting in an office in, Clarion, Pennsylvania, and you're not, well, actually you're close to the university there. All right, another city, someplace in the middle of Pennsylvania without access to a university library, that you can use the Internet to connect you to a community of people who know about this and who can advise you. When I was working in a practice setting, again, as I mentioned, as director of research, I depended on colleagues a great deal to help me out. And so we would use email, and oftentimes there are listservs that you can go on. You can belong, and it doesn't cost anything to. And people send emails out all the time. Hey, could you give me? Does anyone know of a good measure with some psychometric properties like validity or reliability about social support? And then people will say, check out such and such. So it takes time, but I believe the Internet has really created a community for people that we didn't have before. So I would always check the classic sources, something like Corcoran and Fisher. But then I would also search using something like Google Scholar or PubMed, which is free.
Mm-hmm. Yeah, it's the government.
Yeah. Right. To start to type in some general search terms, narrow from there, and see if you can find the names of people or access to free articles. They're out there.
I think that's great. And we can put a link to Google Scholar and PubMed and the books that you mentioned. And one thing that I did before I went back to get my PhD was I was still in contact with my professors. And so I'd send them an email or I'd call them and I'd say, hey, what about this? And of course, it's easy for them, especially now, although it was less easy back then. It's really easy now because almost everything is a PDF file. And they can say, okay, great. Well, here's the PDF file. So
absolutely. I get emails all the time from students, particularly when I've taught overseas in Portugal. I just got an email last week saying we really are interested in a measure of developmental changes for children, and we know it won't be in Portuguese, but could you send us some articles in English that might point us in the right direction? So I respond to those emails all the time. So yes, people keep the emails of your professors and send them emails about, once you're in practice. These are really good connections to keep up. And social work professors are always happy to, I believe, to continue to respond to people for requests, because my goal when people leave a Foundations of Research class is for them to incorporate this into their practice. And so I will support that in any way when they leave. And so I've been known to do that a lot, send articles, find the PDF files for people, and email them to them so that they can do this, so that perhaps lack of access to electronic database doesn't hold them back from doing it.
Mm-hmm. Well, that sounds very generous. I didn't have any other questions about measurement. Are there any other hot topics that you think would be important for social workers to know about measurement that we haven't touched on yet? And if not, that's okay.
My last comment, Jonathan, would be that measurement is important for social work. Once again, we often think it's the domain of psychologists, but the fact is that measurement can be used against people, or it can be a force for social justice, which is important for social work. And so I think it's important for social workers to be concerned about measurement and how it's used, and to to realize that it's just simply not the domain of certain specialists, but rather it belongs to the field as well, the field of social work, and for us to be concerned about how certain things are measured and sometimes how they're used. For example, IQ, that's a whole other podcast. But for us not to believe that measurement is simply the domain of research and not areas that are traditionally more associated with social work, justice, community, etc.
And as you said that, it made me think that people in the field typically do not develop the measures, even though they might be consulted by those who do. But there are a number of measures that are developed ostensibly for the field. And so it sounds like one of the ways that social workers can think about it is, if I really want to make an impact on this measure, I need to actually use it and give feedback.
Yes.
I can't just say, well, I didn't develop it. It was developed in an ivory tower, so therefore it has nothing to do with me. But rather to say, you know what? I have to use this. I'm going to let them know what I think.
Exactly.
This doesn't work. It's 113 items.
Right. Email, call, send letters. Absolutely. Because measures should be revised. If they're not working, then we need to know about it, and so there needs to be feedback. It just doesn't go out in a journal and that's it. It's the gold standard forever. So yes, people should feel free to contact the developers to talk about it. And the other thing is, even though I have encouraged people not to create their own measures, I would tell you that you can do it, and you can do it in a collaborative environment. So if you're out working in the field and you really see a need for something, I would encourage you to try to find other collaborators, including some people in universities, perhaps faculty that you've worked with in the past in your program, to work together. I mentioned in the earlier podcast the REMY. That wasn't developed out of a university. That was developed by 5 practitioner researchers who work in provider settings, Casey Family Programs, Presley Ridge, Girls and Boys Town. So it was developed with working in conjunction with some people from George Washington University, and with the University of Washington. So you can see I'd like to see more practitioners saying, hey, we really need a new measure of such and such, and working together. I might add, actually, without a budget, it was all in kind. So it wasn't like you need a lot of money. You just need time and expert and help. So while I'm not suggesting that every practitioner go out and try to measure something, I will tell you that it can be done. And so not to be close to that possibility.
And you're actually talking about a measure, an instrument that could be used outside of the specific setting in which it was developed. You're actually talking about developing something with good psychometric properties and things like that, which is different than creating the kinds of scales that Insoo Kim Berg talks about in solution focus treatment, where you say, okay, so mom, tell me about what's going on with you. Okay, so on a scale of 1 to 10, this is your own personal scale that's just for you. So those are 2 different types of scales.
Exactly. And you can use, they're both useful. You have great utility. They're for slightly different purposes. Mm-hmm. The purpose is different. But yes, you can do both in a practice setting. And so social workers should also consider the fact that while they can do something that is unique perhaps to one client or one situation, working in collaboration, they can also create something that has a different purpose and can go on to create the body of knowledge that validates that tool. So we can do it all, Jonathan.
We can do everything. We're social workers. All right. Well, Mary, thanks so much for talking with us today about measurement. It was a real pleasure.
Well, thank you for inviting me. It was wonderful. Thanks.
I'm Jonathan Singer, and thanks for being with me today for another episode of the Social Work Podcast. If you missed an episode or have suggestions for future episodes, please visit socialworkpodcast.com. If you'd like to support the podcast, please visit our online store at cafepress.com/swpodcast. To all the social workers out there, keep up the good work. We'll see you next time at the Social Work Podcast.